الاذر توك المنتظره ان شاء الله في السيشن اللي جايه متعلقه بالتراكيوستومي التكنيك والكومبليكيشن. الشير بيرسون اتفضل الاستاذ الدكتور محمد القادر، الاستاذ الدكتور محمد غفار، والدكتور صلاح خليفه. يعني شرفنا لو كان موجود، يعني سعدنا يكون موجود معانا.
التراكيوتومي دلوقتي عن التكنيك الديفيكالتس والكومبليكيشنز، والدكتور محمد عبد المتين هيبدا بقى يكلمنا عن الحاجات دي. اتفضل.
السلام عليكم. معكم محمد عبد المتين، lecturer of otorhinolaryngology, Sohag University. I am honored to be a speaker in the 5th ORL conference of Sohag. Today's topic will be tracheostomy, how to do it. Tracheostomy is one of the important life-saving procedure every ENT surgeon should be familiar with. It is a stressful operation. The surgeon is fighting against time, so we should know everything about it. The first question is, what's tracheostomy? Tracheostomy is an operative procedure to make an opening in the tracheal wall to create an artificial airway. And in the beginning, let me take you to a brief tour in the history of tracheostomy. Tracheostomy first described in the first Egyptian dynasty in King Hor temple in Abydos in 31,000 BC. And this picture is taken from the temple of King Hor. It's reported in the ancient Hindu scripts in 2000 BC and reappeared in the Egyptian history in 15,000 in Egypt papyrus, which is an ancient medical reference. In 100 AD, Asclepiades of Bithynia credited to form the first elective tracheostomy. In 1615, a novel surgical pathologist called Theophilus Pontus has described the first pediatric tracheotomy for a 7-year-old child who was choking with a bone. In 1870, a neurologist called Tourvoisier reported that 200 patients with diphtheria was saved by tracheostomy. Tracheostomy is one of the ways to save the airway. We should also know other ways to save the airway. First one is the endotracheal intubation, which is easy and feasible, and if possible, we do it. If not, we do cricothyroidotomy with different technique. Needle cricothyroidotomy, percutaneous cricothyroidotomy, or open cricothyroidotomy. And the tracheostomy in two techniques, surgical tracheostomy and percutaneous tracheostomy. Now, we must know the function of the tracheostomy, which is bypassing obstruction, an airway and oxygen port, allow pulmonary lavage in patient with weak cough reflex, patient with chronic aspiration, we do 8 to 2 fights aspiration, and decreasing the dead space. And this can lead us, and we can imagine what is the indications of tracheostomy. Now we can classify tracheostomy into emergency tracheostomy and elective tracheostomy. The emergency tracheostomy is done to bypass the airway obstruction as in patient with neck trauma, facial trauma, laryngeal paralysis, laryngeal pathology, tumors, impacted foreign body aspiration if the bronchoscope is not available or difficult, in patient with laryngeal edema as with patient with angioneurotic edema. And the elective tracheostomy, we do tracheostomy in case of extensive neck surgeries or maxillofacial surgery. Patient expected to have prolonged ICU intubation. Patient with chronic aspiration and laryngeal paralysis. Patient with severe obstructive sleep apnea and not candidate for CPAP or other surgical intervention. And at the end stage of total laryngectomy. Before we talk about the procedure itself, we should be familiar with the field we are playing in. The cervical trachea is present in the midline of the neck, superficial, covered only by skin, superficial fascia, platysma, and partially covered by the thyroid isthmus. connected upward with the cricoid cartilage of the larynx, and continuous downward with the thoracic trachea through the thoracic inlet. The thyroid isthmus present in front of the trachea rings, second, third, and sometimes they call the fourth. Posterior to it lies the esophagus, and lateral to it the great vessels of the neck, and the recurrent laryngeal nerve run in the tracheoesophageal groove, as we can see in this picture. Now we are taking this patient to the operative theater. In elective cases, we should do our all investigation, especially imaging and laboratory. The consent, well-informed consent, should be taken from the patient and his relative if he is unconscious. The position, we put the patient in the supine position with neck extended using a sand pillow below his shoulders. We sterilize the area between the chin to the upper chest using bovet iodine or betadine. The type of anesthesia used in patient with tracheostomy, general anesthesia if available and feasible, if the anesthesiologist can access the larynx. If not, we use the local anesthesia. Sometimes we didn't use anesthesia in patient is severely distressed or comatose. We use 2 incisions, longitudinal and transverse. The longitudinal incision, we usually use it in patient with emergency as it's easy and time saving. We use the transverse incision in patient اللي هم بيبقوا elective لأن هو more cosmetic عن longitudinal. After we incise skin, subcutaneous and platysma, we are now facing the strap muscles. We split the strap muscle with blunt dissection using mosquito forceps and L-shaped retractor till we reach the thyroid isthmus. The thyroid isthmus, we either divide it and ligate it or retract it upward with a retractor. Once we see the thyroid isthmus, that means that we are above the second to fourth tracheal ring. In this picture, there is the thyroid isthmus. After splitting the thyroid isthmus, we can see a white structure in the midline, which mostly is trachea. To get sure that this is trachea, we aspirate from it using a needle. And a trick, we use it in Sohag Hospital, that we inject diluted lidocaine to decrease the cough reflex and decrease the blood spill after opening the trachea. We open the trachea by 3 techniques. The first one is tracheotomy by taking 2 stay sutures in the size of trachea and making a longitudinal incision, and you usually use it in the pediatric tracheotomy. Or we open the trachea by removing part of the anterior wall, which is the traditional one, or using a Bjork flap by taking a flap from the cartilage and suturing it to the skin. And you use the Bjork flap usually in the patient in the ICU. بنستخدمه في حالات الاي سي يو لان هو بيبقى مور اكسسبل في السكشن، ان هو حتى لو حصل ديسلوجمنت اوف ذا تراكيستومي تبقى التراكيه قدامه فيقدر يركبها تاني ايزلي من غير ما العيان يتخنق منه. طيب الليفل اللي بفتح فيه التراكيه انا عندي 3 ليفل: هاي، ميد اند لو. The high level we do it at the level of the first tracheal ring. We didn't usually use this level because I will injure the cricoid cartilage causing perichondritis and followed by subglottic stenosis. I use it only when there is laryngeal cancer and I want to preserve the upper tracheal ring for total laryngectomy. The lower level, we use it when we suspect that the tumor is reaching the upper tracheal ring and I want to bypass the obstruction, but we didn't use it usually because there is important structure passing by there, like the innominate artery. Injury of it can cause severe bleeding, and the pleura, which when injured will cause pneumothorax. The ideal one and the most used one is the mid-tracheostomy. After we open the tracheostomy, we must choose our tracheostomy tube carefully. The size of the tube, we use it according to the size of trachea and size of opening I had made. The type of the tube, which is different in the material and the function. In the material, we could see the silver, the metal, the silicone, and the plastic. Silver and the metal are now obsolete. We are using either silicone or the plastic. Fenestrated or not fenestrating according to the patient. إذا هيبقى permanent tracheostomy ولا transient tracheostomy. We use it the classic one or the inner outer RD cannula or bicannula tracheostomy. برضو according to the patient اللي موجود قدامي. الهيموستاسيس, after I end my procedure, I must be sure that I did good hemostasis to avoid postoperative bleeding. And I close the wound using loose suture to avoid surgical emphysema postoperative. And then I have to stabilize my tracheostomy tube either by suturing to the skin or using Mateen to the neck of the patient. After I end my operation, before sending the patient to the ward, I must do chest X-ray to detect early if there is a pneumothorax and must be consulting the cardiothoracic surgeon. I must use broad-spectrum antibiotic to avoid infection, good mucolytic, frequent suction from the tube, local care of the tracheostomy wound, and I must never remove the tube before 4 days before the patient has a well-formed tract. My take-home message is, tracheostomy is important, a life-saving procedure. We must all know how to do it. When you think a tracheostomy for a patient, you must do the tracheostomy. Choose the technique you are familiar with. Post-operative X-ray is mandatory. شفنا حالات كتير دخلت في tension pneumothorax post-operative. Don't remove the tube until it makes stable track. And thank you.